So imagine for a second that you are managing severe treatment-resistant depression and menopause at the exact same time.
Which is an incredibly complex balancing act for anyone.
Right. But let's say you finally found stability, using a daily antidepressant and a standard estrogen replacement.
Okay.
Then, perhaps just for convenience or maybe due to a change in insurance, you swap your standard transdermal estrogen patch for an oral birth control
A
pill.
very common scenario, yeah.
You take that pill, and within a matter of hours, the blood concentration of your antidepressant spikes by like 2,000%.
Oh, wow.
Without warning, you are suddenly facing a tyramine-induced hypertensive crisis, placing you at imminent risk of a fatal stroke.
It is a terrifying scenario.
Yes.
And what makes it so chilling is that to the average person, or honestly, even to a busy general practitioner, swapping one form of estrogen for another seems completely benign.
Because we assume estrogen is just estrogen, right?
Exactly. But when you are dealing with overlapping, complex pharmacological regimens, the route of administration doesn't just change the convenience, it completely rewrites the chemical rules of engagement in your body.
Which brings us to the core mission of today's deep dive. We are looking at a highly specific, high-stakes question for anyone navigating these multiple therapeutic landscapes.
Yes.
Can you safely use transdermal HRT, so hormone replacement therapy like an estrogen patch or gel, alongside transdermal psychiatric medications?
It's a huge question.
It is. And we have a massive stack of sources in front of us today, including clinical pharmacology guidelines, the latest recommendations from the British Menopause Society, and some incredibly dense drug interaction databases.
Very granular stuff.
Yeah, but we are going to sift through all that noise and extract the truth about mixing these skin-based systems. So, okay, let's unpack this.
Let's do it.
Before we even get into the volatile chemistry of combining these treatments, we have to look at the baseline. I mean, why bypass the gastrointestinal tract at all?
Well, the appeal entirely comes down to dodging first-pass metabolism.
Okay, what does that mean in plain English?
So when you swallow a standard oral medication, it hits the GI tract, absorbs into the portal vein, and is immediately shipped to the liver. And the liver acts as this massive, highly aggressive metabolic toll booth.
Right.
Its primary function here is to metabolize and break down foreign substances using specialized enzymes before those substances ever reach your systemic circulation.
So by the time the active pharmaceutical ingredient actually gets to your brain or whatever tissue desperately needs it, a huge percentage of it has already been structurally altered or, completely dismantled.
Exactly.
I always think of the liver like a notoriously strict bouncer at a club. Like he rigorously searches you and arbitrarily confiscates half your belongings before finally letting you through the doors.
That is a perfect analogy.
Oh.
And transdermal patches, well, they act as the VIP side door.
Because they bypass the bouncer entirely.
Exactly. They provide the drug with direct, unfettered access to the capillary beds right under your skin. And if we connect this to the bigger picture, gaining that VIP access radically changes the pharmacokinetic profile of the drug.
In a good way.
Usually, yes. Instead of the massive peaks and valleys you experience with an oral pill, where the drug spikes in your bloodstream and then rapidly drops off as the liver clears it, a transdermal system delivers the drug steadily and continuously.
So you just maintain a constant hum of medication.
Right. And for the patient, this usually translates to better overall adherence, a much smoother therapeutic effect, and vastly fewer gastrointestinal side effects, which is why they are so appealing for both HRT and sensitive psychiatric treatments.
Okay, wait, I'm stuck on something here, though.
Sure.
If human skin has literally evolved over millions of years to be an impenetrable armor, to keep bacteria and toxins out of our bloodstream, how is a tiny piece of adhesive hacking our cellular biology to let a heavy-duty antipsychotic or a hormone slip past that barrier?
It's a brilliant piece of biochemical engineering, honestly, because not every drug can be formulated into a transdermal patch.
Right, you can't just put anything in a patch.
No, not at all. To successfully breach the stratum corneum, which is the highly resilient, dead outer layer of your epidermis, the drug molecule has to meet incredibly strict physical criteria.
Like what?
First, it must have a very low molecular weight, typically well under 600 grams per mole. It just has to be physically tiny. Second, it must be highly lipophilic, meaning it dissolves easily in fats.
Ah, because the mortar holding those dead skin cells together is primarily made of a dense lipid matrix.
You've got it. The stratum corneum is often described as a brick and mortar structure, where the keratin-rich skin cells are the bricks and the lipids are the mortar.
That makes sense.
But even if a drug is small and fat-soluble, that is rarely enough on its own. Patch manufacturers almost always have to impregnate the adhesive with what are known as permeation enhancers.
Permeation enhancers, like what?
These are specialized compounds like certain alcohols or fatty acids that essentially fluidize the skin's lipid bilayers temporarily.
Wow.
Yeah, they chemically reorganize the mortar just enough to let the drug molecules slip through the cracks without permanently damaging the skin's barrier function.
That is wild. So the patch is actively dissolving a temporary microscopic doorway in your armor.
Exactly.
And because this delivery method avoids the liver entirely, the way your body handles the medication is totally transformed, which naturally alters the risk profile.
Radically alters it, yeah.
Let's look at how this applies to hormone replacement therapy, specifically regarding mental health, because the data from the sources here is striking.
It really is. For decades, the default standard of care was oral estrogen. But when oral estrogen hits that liver toll booth we talked about, it triggers a chain reaction.
Okay.
It stimulates the liver to dramatically ramp up the production of certain coagulant proteins. And this is the physiological mechanism behind why oral HRT carries a well-documented risk of venous thromboembolism, VTE, and an increased risk of stroke.
But transdermal HRT changes that mathematical risk entirely, right?
It does.
The British Menopause Society guidelines show that transdermal HRT, like Everol, Fem7, or Estradot patches, completely avoids those prothrombotic effects in the liver.
Exactly. For a patient using standard transdermal estrogen, their risk of VTE and stroke remains neutral.
Meaning it's statistically the same as someone not using HRT at all.
Right. The cardiovascular safety profile is vastly superior, but the benefits for the central nervous system are where the data gets really compelling for our deep dive today.
Yeah, the sources highlight a recent robust study tracking over 3,800 postmenopausal women.
A very significant sample size.
Definitely. And the findings indicated that those utilizing transdermal HRT had a significantly lower incidence of clinical anxiety and depression compared to the group using oral HRT.
Which makes perfect sense when we think about the continuous delivery mechanism.
Because there's no roller coaster effect.
Precisely. The brain's neurotransmitter networks are notoriously sensitive to fluctuating hormone levels. If you're taking a daily oral pill, your brain is riding a biochemical roller coaster of peaks and troughs every 24 hours.
And that instability alone can trigger severe mood lability.
Yeah, the patch smooths that out, providing a constant baseline.
But looking at the literature, there is a massive psychological trap here called tachyphylaxis, which seems completely counterintuitive to everything we just discussed.
Oh, tachyphylaxis is one of the most dangerous hurdles in long-term transdermal hormone management.
Okay, what is it exactly?
By definition, it is a rapid decrease in response to a drug following repeated administration.
Right.
In the clinical reality of HRT, you might have a patient who has been doing beautifully on an estrogen patch for months.
Right.
But suddenly she feels her mood slipping. Perhaps the vasomotor symptoms like hot flashes start returning, and she concludes that she has built a tolerance.
Like her patch is no longer strong enough. Wait, so if you're a patient feeling your mood dip, your immediate instinct might be to ask for a higher patch dose, right? But the sources indicate that escalating the dose outside of licensed guidelines could actually trigger the exact psychiatric symptoms you're desperately trying to escape.
Yes, what's fascinating here is the delicate chemical balance of hormones. The paradox lies in how the brain's estrogen receptors downregulate.
Okay, break that down for me.
When patients chase symptom relief by continually increasing their patch dose, they invariably push their systemic estrogen into what we call supraphysiological levels.
Meaning way higher than normal physiological levels.
Exactly. They're flooding their system with excessively high estradiol. And the brain's response to this massive overexposure isn't to feel calmer or more balanced.
It's not.
No. Instead, the receptors essentially become overstimulated and dysfunctional. The result is severe low mood, intense irritability, and crippling anxiety.
It's like trying to get better sound out of a stereo by just cranking the amp all the way up to 11.
Yeah.
You don't get clearer music, the speakers just blow out, and all you get is deafening, distorted static.
That is a highly accurate way to visualize it. The brain's receptors are getting so flooded with estradiol, they essentially short-circuit, triggering panic instead of peace.
Wow.
And consider the vulnerability of the patient population we are discussing today. Women who already have pre-existing mental health diagnoses, major depressive disorder, generalized anxiety, schizophrenia, they are uniquely, exquisitely sensitive to these superphysiological hormone spikes.
Right, because their baseline is already compromised.
Exactly. Throwing unregulated, massive amounts of transdermal estrogen into their system will inevitably exacerbate their baseline psychiatric symptoms.
Which brings us to the ultimate focal point of our analysis today. If we have a patient with a complex psychiatric baseline and they are successfully safely managing their menopause with an HRT patch, what happens chemically when they literally stick a transdermal psychiatric medication onto their skin at the exact same time?
Well, to map out those interactions, we have to isolate the specific psychiatric patches currently dominant in the pharmacological landscape.
Okay, let's name them.
We're primarily looking at asenapine, which is prescribed under the brand name Sequado for the treatment of schizophrenia, and selegiline, known as MSAM, which is a powerful patch utilized for major depressive disorder.
Let's start with asenapine. Looking at the drug interaction databases, the guidance is pretty unambiguous.
It is.
Asenapine has a documented moderate to major interaction with transdermal estradiol, specifically listed alongside products like Estrapatch,
It does, and the mechanism here involves clearance rates.
meaning how fast the body gets rid of the drug.
Yes, exogenous estrogen can significantly alter how efficiently asenapine is metabolized and cleared from the systemic circulation.
Okay, so what happens if they are combined?
If a patient arbitrarily combines these two transdermal systems without strict medical oversight, they risk a toxic accumulation of asenapine.
Oh, because it's not clearing out fast enough.
Exactly. This drastically elevates the probability of severe adverse effects, particularly extrapyramidal symptoms like involuntary muscle movements, profound sedation, and potentially dangerous alterations in cardiac rhythm.
So for asenapine, it's not an outright contraindication, but it requires meticulous collaborative calibration between a psychiatrist and an endocrinologist.
Absolutely.
But here's where it gets really interesting. Let's look at selegiline. Selegiline is a monoamine oxidase inhibitor, an MAOI.
Right, those are heavy-duty antidepressants.
Yeah, they are known for having incredibly strict interaction rules, and the clinical data reveals a terrifying divergence depending entirely on the specific type of estrogen you expose it to.
This specific interaction perfectly illustrates why an intricate understanding of pharmacology is life-saving.
Tell me about it.
If a patient is utilizing an oral birth control pill, which relies on a synthetic estrogen compound called ethinylestradiol,
Okay.
and they simultaneously apply a selegiline patch, the serum levels of selegiline will violently escalate by a factor of 10 to 20.
Wait, just to put that in perspective, a 20-fold increase is a 2,000% spike in the circulating drug level.
Exactly. And when you are dealing with an MAOI like selegiline, a 2,000% spike immediately obliterates its carefully engineered safety profile.
Because MAOIs require those strict dietary limitations, right?
Yes, regarding tyramine, which is found in aged cheeses, cured meats, certain wines. At normal doses, the selegiline patch bypasses the gut, often allowing patients to avoid those strict dietary rules.
Oh, that's a huge benefit.
It is. But at 20 times the intended dose, the MAO enzyme inhibition in the gut is profound. The patient is thrust into an imminent risk for a tyramine-related hypertensive crisis, where their blood pressure can reach catastrophic stroke-inducing levels within minutes.
That's the scenario we talked about at the very beginning. But let's go back to our hypothetical patient. If that exact same patient swapped out the oral birth control pill and instead uses menopausal transdermal HRT, a standard estradiol patch, the selegiline levels only experience a modest bump of about 59%.
Right, a fraction of the oral reaction.
It doesn't trigger the catastrophic 2,000% spike. Why does the origin of the estrogen, the synthetic pill versus a transdermal patch, determine whether a patient is perfectly safe or facing a fatal stroke while using the exact same antidepressant?
The answer is found back at the liver's metabolic toll booth.
The bouncer.
The balancer,
Yeah.
right. Specifically looking at a family of enzymes known as cytochrome P450, or CYP enzymes. Ethinylestradiol, the synthetic hormone used in oral birth control, is chemically armored.
Chemically armored.
Yes, it is purposefully engineered to survive the highly acidic, destructive environment of the digestive tract. But when that rugged synthetic molecule hits the liver, it binds to and aggressively inhibits those CYP enzymes.
It essentially occupies all the toll booth operators.
Exactly. It shuts down the liver's capacity to metabolize other concurrent drugs.
So because the liver's CYP enzymes are completely disabled by the oral birth control, the selegiline from the patch has nowhere to go. It just continually backs up and accumulates in the systemic circulation until it reaches those terrifying toxic thresholds.
Precisely the mechanism. But modern transdermal HRT utilizes body-identical estriol. It is structurally indistinguishable from the molecule your own ovaries synthesize naturally.
Oh, I see.
Because it is delivered through the skin's VIP side door, bypassing that first-pass hepatic metabolism. It doesn't storm the toll booth. It does not aggressively inhibit those crucial CYP enzymes.
Wow.
Therefore, the liver retains its full functional capacity to process and clear the selegiline at a normal, safe rate.
It is a stunning example of how the specific route of administration dictates the entire safety protocol of a therapeutic regimen.
Completely dictates it.
So, chemically speaking, combining transdermal HRT with a psychiatric patch is not only possible, it is demonstrably safer than utilizing oral synthetic estrogens, provided the prescribing physicians are acutely aware of the specific pharmacological pairings.
Absolutely.
But solving the liver enzyme traffic jam doesn't mean we are entirely in the clear. By keeping these highly potent medications on the surface of the skin, we introduce a completely different physical vulnerability that patients have to manage.
Yeah, the physical logistics of transdermal application are deceptively complex.
How so?
Well, the fundamental rules of geometry and dermal integrity apply. Patients can safely wear multiple patches concurrently, but they must be affixed to clean, dry, hairless, strictly intact skin.
Okay, standard bandage rules, basically.
Yes, but crucially, they must never be allowed to overlap. Overlapping patches can chemically degrade the adhesive, compromise the protective backing, and unpredictably accelerate the diffusion rates of the active pharmaceutical ingredients.
Just space them out. But the most severe physical vulnerability, the absolute nemesis of the transdermal patch, is heat.
Oh, without a doubt. External heat sources are exceptionally dangerous for anyone relying on a transdermal system.
Like what kind of heat?
We're looking at everyday environmental factors.
Yeah.
Electric heating pads, heated blankets, saunas, hot tubs, prolonged exposure to intense direct sunlight, or even a severe internal biological fever.
The pharmacological literature refers to this as dose dumping, and the mechanics of it are alarming.
Very alarming. When your localized skin temperature rises, two critical things happen simultaneously.
Okay.
First, the cutaneous blood vessels aggressively dilate, drastically increasing blood flow to the application site. Second, the thermal energy increases the kinetic movement of the drug molecules embedded within the patch.
And what does that combination do?
It completely destroys the patch's controlled release mechanism. The patch rapidly discharges its entire payload.
Oh, no.
Yes, a highly calibrated dose engineered to absorb slowly and safely over a 72-hour period can suddenly dump into the systemic circulation in a matter of hours.
You know, think of the transdermal patch like a highly concentrated tea bag.
Okay, I like that.
If you drop a tea bag into pleasantly warm water, which is essentially your normal basal body temperature, it steeps perfectly, right? Releasing its compounds slowly over a long period.
Right.
But if you take that exact same tea bag and plunge it into violently boiling water representing a hot tub or a heating pad, the structural integrity fails. All the flavor, or in this case, an incredibly potent psychiatric drug or hormone, dumps out instantly and completely ruins the cup.
The toxicity of dose dumping cannot be overstated. When dealing with potent MAOIs, antipsychotics, or opioid analgesics like fentanyl, an accelerated release isn't merely a temporary side effect.
It's much worse.
It induces severe, acute, systemic toxicity that can rapidly become fatal.
And heat isn't the only way to accidentally bypass the controlled release. The sources extensively warn against the common patient habit of cutting patches to adjust a dose.
Yes.
Like someone might think, well, my anxiety is low today, I'll just take some scissors and cut my selegiline or estradiol patch in half.
Altering the physical structure of a patch is fraught with hazard, and it heavily depends on the specific engineering of the system.
There are different types of patches, right?
Yes, transdermal patches generally fall into two architectural categories: reservoir patches and matrix patches. A reservoir patch contains a distinct, literal pouch of liquid or gel medication separated from your skin by a highly specific rate-controlling membrane.
Okay.
If you cut a reservoir patch, you physically slice open the pouch and destroy the membrane. The entire liquid volume of the drug leaks out directly onto the skin, resulting in an immediate, massive overdose.
You're completely breaking the dam.
Unquestionably. Now, matrix patches operate on a different design. In a matrix system, the drug is homogeneously embedded throughout the solid adhesive itself.
So it's mixed in.
Exactly. Technically speaking, slicing a matrix patch doesn't induce a catastrophic leak because there is no liquid reservoir to rupture.
So those are safe to cut.
No, not casually. Under very specific, closely monitored medical authorization, some physicians will prescribe off-label cutting of a matrix patch to highly customize a pediatric or sensitive dose.
But generally, it's a bad idea.
The British Menopause Society and all major pharmaceutical manufacturers heavily advise against this practice. Cutting the patch mathematically alters the intended geometric surface area and can severely compromise the predictability of the controlled release.
So unless explicitly directed by a specialized prescribing physician, scissors should never touch a transdermal patch.
Never.
Which brings us to the final physical vulnerability, the disposal. Because the danger doesn't magically evaporate the moment your 72 hours are up and you peel the patch off your hip.
Safe disposal is a critical public health issue, particularly concerning psychiatric and analgesic patches.
Why is that?
When a patient removes a patch at the end of its therapeutic life cycle, the patch is far from empty. Transdermal systems are over-engineered. They retain a highly significant residual concentration of the active pharmaceutical ingredient even after use. Yes, if a patient casually discards an exposed patch into an open bathroom wastebasket, it becomes a severe environmental hazard.
Because that residual drug is still perfectly capable of crossing the skin barrier of whoever or whatever finds it.
Exactly. There is a deeply tragic, well-documented history of toddlers or household pets discovering discarded fentanyl or psychiatric patches in the trash.
Oh, that's terrible.
They will often play with them, stick them to their own arms, or ingest them. And a residual dose that is pharmacologically insignificant to a 180-pound adult will quickly metabolize into a lethal overdose for a 30-pound child.
So what's the proper way to handle it?
The absolute protocol for disposal is to firmly fold a patch in half, sticky sides together, sealing the residual drug inside its own backing, and then immediately depositing it into a secure, pet-proof trash receptacle or the designated pharmaceutical disposal unit.
So synthesizing everything we've explored today from these clinical guidelines and pharmacological databases, what is the final verdict? Can you safely use transdermal HRT alongside transdermal psychiatric medications?
The answer is a definitive yes.
And not only is it possible, but utilizing that transdermal VIP side door offers profound clinical advantages, doesn't it?
It really does. You stabilize mood far more effectively than with oral dosing. You completely bypass the hepatic prothrombotic risks of blood clots, and you avoid the catastrophic, potentially fatal enzyme interactions we see when mixing heavy-duty psychiatric drugs with oral synthetic birth control.
Right. But I mean, that yes is contingent on a foundation of absolute hypervigilance.
Absolutely.
Oh.
It requires precise pharmacological mapping by your medical team to navigate specific clearance interactions, like those seen with amlodipine.
And it requires deep patient self-awareness, too, to recognize and avoid the psychological trap of tachyphylaxis and that unauthorized dosage creep.
Yes, and it demands strict physical discipline regarding your environment, maintaining core temperature, avoiding external heat sources, understanding the engineering of your specific patch, and executing meticulous disposal protocols.
It is an immense amount of responsibility to manage. But for patients navigating the labyrinth of overlapping severe health conditions, mastering this transdermal balance is life-changing.
It fundamentally reshapes the patient experience. And, looking at the sheer sophistication of these systems, it raises an incredibly provocative question about where pharmacology is headed in the future.
Oh, yeah. What's that?
We have been culturally conditioned to view our skin merely as a passive protective shell, just a wrapper designed solely to keep the chaotic outside world away from our fragile internal biology.
Right.
But the science of these advanced transdermal systems reveals the skin as something infinitely more profound. It is a highly permeable, exquisitely sensitive, programmable interface that connects directly to the brain and the endocrine system.
It really is an interface.
It is. It forces us to ask, what if the future of treating complex, overlapping health conditions eventually abandons the primitive pill bottle entirely?
Oh, wow.
What if the pinnacle of modern medicine relies on a customized second skin? A networked array of smart transdermal patches, continuously communicating with each other, reading our biometrics in real time, and perfectly orchestrating our internal chemistry without ever involving the digestive tract.
That is a fascinating future to imagine.